I have a methods question, so there's a lot that's been said about sort of evidence-based design, this, that, and the other, but you can't really do A/B testing with the number of cities we have at our disposal and the number of neighborhoods and the number of projects. So how do you, say, test the mental health implications of, say, a terminating Vista, to borrow something I hear from ULI all the time? When you don't have that kind of control, you can't create control in the experimental population, and you don't have very many data points. So, I mean, what does actual research in this field look like?
I'm hoping Yonette's going to take this one.
Well, actually, no, I was saying, yeah, thank you for asking that question. It's a problem, because when you're doing human research is noisy. I'm always jealous of my colleagues who have zebrafish in a dish. It's really easy. So, when you're reading, right, no RB approval needed. Right, and that's another big issue. It's a real issue, but I think what we have at our disposal are natural experiments. We see changes occurring, and we have to look at how that change unfolds. I was listening to you talk about something happened in the last year. And we have a sense of what happened, what was going on before then, and we have communities where that's not necessarily happening. We have people who are making an effort not to dispose their kids to that. So we have to look for some pseudo-normative comparisons. The controls will be as noisy as the experimental group, but that's what we have because we're human beings, and cities are noisy. So to answer it on the method side, we deal with that every day, and you have to kind of wash out some of that noise. That's the best I can tell you.
If I may, so in some of the work that we've been doing in the healthcare side and the very clinical and looking at, for an instance, just one exam room, and that one exam room by evidence doesn't fit all populations. So we kind of have to go in each time with that empathetic side of, okay, who are the patients they're treating? Is it a federally qualified health center that treats the low income, so Unity Healthcare, for example? Is it Whitman Walker, which is also federally qualified, but really focuses on the LGBTQ community? Can one exam room really do both? So we do qualitative research where you don't have the strict quantifiable control groups, the variables that you would, but it helps us create a space that understands that population. So we go in with surveys and observation and behavioral mapping each time to say, even for something as simple as an exam room, how do we get it so that one, we keep the infection rates down in the exam room, and two, we provide the privacy that patients need in there. And we've come out with different ends for each one, for each community, even if they're in the same city. Even so far as, hand washing is a big deal in all healthcare components for reducing acquired infection, even in an outpatient setting and a clinical examination setting. But with the LGBT community who was historically treated just for HIV, having the sink front and center and the doctor washing their hands in front of them reminds them that they're stigmatized and the doctor doesn't want to touch them because they might be contagious. So we take the sink away from the front position, which is very different in other populations where the parents of the children that are being treated by their doctor know that there was a kid with the flu next door, want to see that doctor and that nurse and that tech wash their hands for longer than 2 minutes, 3 times while they're in the room with their child. So it's something that we have to look at each time we begin a new kind of planning, a new exercise, a new design project.
I would just quickly add, I love that question, but in the transportation and government world, we're awash in money and doing research all the time, but we don't know the questions to ask in mental health. I think that a lot of DOTs would love, and we do tons of before and after studies, and we do lots of studies where we go out and ask people, how do they feel about this and that and this before and after, but we don't know what to ask. And unless the mental health community gets involved with city planners and starts to feed them the right questions to ask people that you want to know the answers to. Because I think there are resources, at least in a lot of the DOTs that I work with, that would love to have some good questions to ask people.
When I heard Layla begin the presentation, it made me think of what the organization I work for does for landscape architecture, but in this context for mental health and urban design. I work at the Landscape Architecture Foundation, and we fund research on high-performing landscapes. So we look at the environmental, social, and economic outcomes of high-performing landscapes. And we're just starting to look into the mental health component of social. But going back to IRB approval, it's complicated when you're working with people. And some of the deliverables that we've been creating for the greater industry this year are our guidebook to evaluating performance, and we also have our case study investigation program, which documents case studies on high-performing landscapes. So we see these as tools for policymakers and other professionals, even those going to their clients and saying, look at this project, look how much money was saved, and it's actually more sustainable and people interact more. So I say all that not just to plug LAF, but also to say, you know, what is your ideal iteration of what's to come of this startup think tank in 6 months' time, or whenever you've all convened? What do you think would be that kind of product that would be most helpful to this very interdisciplinary group of professionals?
I think that's a great question. I don't know the answer, that's why I'm speaking to everyone. So yeah, tell me and like send messages and things. I mean, I currently run a public-private partnership in a very different area in global health. And in some ways it's sort of similar. And I've done a lot of work and research in trying to understand what is useful for people who are having to do this stuff in the field. How do you get things from the ivory towers of academia onto the ground? And again, it's going to be difficult for all different populations, and I'm in the medical profession, and I'm trying to understand what do people who are designers or developers want, and I don't know what that's going to look like yet. I'm still trying to figure it out. If other people know, then absolutely get involved in this, please. We've just set up a LinkedIn group, actually. It's only got one member so far, me. However, I think it's called Urban Design and Mental Health. Something. So go on and join that, because I want to be bouncing ideas, and I want to be growing this think tank into lots of different disciplines having views. If people have views, then come and tell me. But for the moment, I think we're going to start off by trying to drag out where is the evidence of things that are associated with urban design and mental health, and try and categorize that usefully to help people find it rapidly. That's going to be the first thing. I think that you're right, it'd be great to build useful toolkits. I don't like to build things just for the sake of them, and you know, sometimes you just churn out things that are not useful, so I think that we need to just tread a little bit cautiously here and start really figuring out what people want and what's going to be useful. And I think this conversation even tonight has been really useful in starting to look at some of those questions.
Can I just say, I think that's a fantastic question, and Layla, I think you're well positioned, because one of the problems, I was listening to my colleague here and I think, so many of my physician colleagues don't really care about where the kids play, or even where their adults walk. And you're a rarity, and I congratulate you for doing that. But in terms of the larger profession, and I spend a lot of time with people in medicine, yeah, well, that's a problem, but it's not our problem. The other thing is, people are doing the research. There's a lot of research out there. What we need to do is bring these pieces together. The interdisciplinarity that I think you're well primed in response to your question and beyond, you're well primed to bring that together, bring the dialogue, and to help people who want to implement this, know how to use that research to find implementation level. The translation is what we need. We don't need more research. We need to translate that research into practice.
Right. Could I just say a few words as well? So I'm glad you pointed that out. And I haven't given up on my colleagues, believe it or not. And in fact, you know, when we first started ParkRx and we went live July 1st, 2013, you know, I was amazed. I was a little worried. I thought, oh, it's going to be, like, I could see who was prescribing. And I was worried it was going to be Dr. Czar, Dr. Czar, Dr. Czar, Dr. Czar, and it wasn't. Every single provider in my health center, and I'm talking, you know, podiatry, you know, psychiatry, people you wouldn't expect to be this interested in this, were coming to me. How do the website? Well, where's the link, you know, to ParkRx? So I was actually very pleased with that, and I would posit that in my profession, the providers of healthcare are also fatigued. I mean, look at where I work. You visited there, Susan, I know. It's a closed, sealed building. There's no ventilation. There are some windows, but there's no green roof. There's no immediate access to nature at all. And almost nobody leaves the building for 8 hours or 9 hours. I'm a rarity, as I'm rare that I leave the building. And I leave in part because I need to have some alone time. So I don't want the social aspect. I really go to a park and get away from people because my job is very social. Right? So, but going back to the research question here, I will remind everybody in here that even at federally qualified health centers, we're the safety net here, right? They're being very quickly forced into this electronic health record. It's good and bad, right? I mean, it's bad in that we spend 16% of our time doing billing documentation rather than actually talking to listen to patients. But it is good in the sense we are collecting data. The data is being collected every single day. We have a universal, it's expected of providers. You have to ask questions about depression, and mental health screening on every single patient, at least once a year. So the data is being collected. I would be very interested to see, from this urban design perspective, especially from a park prescription and my work, perspective, does it change? March these folks, these millions of 20 million Americans over time across, 1,000 community health centers, and these are the most vulnerable if there's a public health, and see what happens. Do they change? We need that science because if you're going to convince your medical colleagues of this, you got to have some science. You got to have some hard data to show that not only does it increase time spent outside in nature, it actually improves health outcomes.
And I think it's a really good point that you're finding these things to use. The thing is, if you develop something really useful, people will use it. And I think that's what I'm really keen to see how we can achieve here at this new initiative. Were you going to speak? Yeah, we're next.
And this is along the lines of a research agenda. So from the urban design and architecture side, and I'm a professor of architecture and urban design, seeing how my students make decisions, a lot of it's based on a strong hunch. And it relies on their past experience, and we coaxed them to make decisions. And so we rely on a kind of Goldilocks factor, that if you've got a good Goldilocks sense that this city feels about right, so other cities should feel about like this one. And to me, one of the key questions, and it underlies almost all of these questions, is the mystery of density. Is you need a certain amount of density to fulfill the walkability of vibrant, safe streets, Jane Jacobs environment. And there's a tipping point when density incurs all sorts of pathologies. And so the serious research question is that sweet spot. How culturally determined is it? How constructionally determined is it? Obviously, the longer a kid has to walk to a park, or if he depends on someone to drive him, the RX isn't going to work. But so this question about density to me is one of those spots where evidence from research, and some of that research comes from public safety issues, which we haven't really heard from sort of the police department, for example, but also goes back to a lot of historical research on density and health. And so to me, as on the urban design and architecture question, that's a form of research that would be hugely important to how we actually shape cities, and when those questions about redeveloping, coming from Arlington County, that's a dirty word, right? Density, you'd think it's a 4-letter word, but it's actually, 7. But you bring that up in a meeting, and that mystery about what the good density is, to me, is part of this question. So it's not so much a question, but it's one of your, there you go, research.